Absolutely. Well, hi guys. I'm Chelsea Kane. I'm a rehabilitation and neuropsychologist. And I work at OSU, thankfully with Kadar and all of his wonderful team. I have two different specialty designations in terms of my training and expertise. And I don't want to bore you with all the details. I'll tell you a little bit about what I do now. And if you want to talk more about my training, you have questions about my background more deeply, I'm happy to talk to you about that. But I want to get into the content and make sure that we have plenty of time to chat more broadly too. So right now I work at OSU. I work in a couple of different roles. I am the consulting neuro and rehabilitation psychologist on the inpatient oncology rehabilitation service. So on that service, we see patients with all sorts of cancer-related conditions, including brain tumor, spinal cord injury, and a whole breadth of nervous system involvements. I also am the consulting psychologist for the burn service, which is an acute care medicine service that is in ICU and then acute services. And I do a variety of functions for them, some of which are in the realm of cognition, but many of which are in the areas of adaptation to disability and injury, coping with pain, and managing stressors associated with your health. I also do outpatient neuropsychological assessment. So essentially that's assessment of cognitive, behavioral, and psychiatric functioning that helps us understand how changes to the brain and how changes in health impact cognitive functioning and other aspects of functioning. So I wear lots of different hats at different times. I've also worked in a number of different settings in inpatient and outpatient medicine. And my specialty is working in complex medical scenarios and primarily in inpatient environments. But if you have any questions, please speak up. And so let's get into kind of what our agenda looks like tonight. I want to make sure that we are having a conversation. So if anytime you have a question or you want something clarified, please just pipe up. You can either raise your hand, you can just start speaking, you can do anything that you like or drop something in the chat. I'll try and keep track of that. And if Kadar, if you could help me with that too, in case I miss something.
Yeah.
So we're going to talk mostly about TBI tonight, because I had to kind of find a way to constrain what we were going to talk about, because there are so many different ways that brains can be injured. Traumatic brain injury is but one of them. And the survivor you're going to hear from later this month, her injury is related to a brain tumor. So we're going to just focus on brain injury in the traumatic space for the next couple of slides, but we're going to talk more broadly across this whole conversation tonight. So we're going to talk a little bit about what a TBI is. And primarily we're going to focus on TBIs that are sustained in adulthood. That's my specialization. And so pediatric brain injury is a whole other area of specialty that I wouldn't step on anyone's toes. And then we're going to talk about mental health, what it is, what it isn't. Also comorbidities and risk factors associated with TBI, how mental health and brain injury intersect and interact. General expectations, if we have time to talk about what happens at different levels of care when you're in the hospital for a brain injury and what you might see and experience and how that relates to recovery. And then hopefully just throughout this process, questions and discussion on whatever topics come to mind. So first off, what is a traumatic brain injury? It's exactly that. It's a brain injury that happens in a traumatic fashion. So something that happens externally to the brain, not something that happens internally. And so a TBI has to include at least one of the following things: a decreased level of consciousness, amnesia, so an inability to form new memories, at least for a brief period of time, skull fracture, or other objective information about neurologic abnormalities. So these are things like bleeding, swelling of the brain, air in the brain space, injuries to the brain tissue itself or the structures that are surrounding the brain. When we have contusions to the brain, we often see them occur in the frontal and temporal areas of the brain. And that's for a variety of reasons. One, we approach the world from the front. We walk in this direction, we don't walk backwards. So when we have impacts with things, it's often affecting the front part of our skull. And the way our skull is formed, we have a lot of smooth surface of bone on the internal back part of our skull. But where our brain meets our eyes, under, we have a lot of really prickly bones. And so if your brain smashes up against the front of your skull, you're going to have it experience this shearing force from touching this bone and from touching these prickly parts of the skull. And so it causes tearing, and it's more likely to cause injury to those orbital frontal structures that are right behind your eyes. So there's some neuroanatomical reasons why we see that, but also just the nature of the types of injuries we see. And I'll talk to you a little bit more in the next slides about that. And there are specific criteria that we use to classify severity of brain injuries. So there are 4 primary categories: mild, complicated, moderate, and severe. This is important because I think when we talk about injuries, whether they be brain injuries, whether they be ankle sprains, we often use terms like mild, moderate, and severe. And sometimes those are very subjective. You know, if I say, oh, I have a really severe ankle sprain, that may or may not be actually based in some kind of diagnostic process. It may just be that, oh, it hurts really bad and it bruised a lot. But that may not actually, that term, you know, severe, may not actually be tied to any clinical indicators and may not actually be related to prognostic information. In the case of brain injury, the way we refer and the way we classify brain injuries not only is grounded in some very specific clinical data that we get early on in the injury, but also it has implications for how a person might be expected to recover and the types of changes they might experience in lots of different areas. So a mild injury, which is also known as a concussion, is an injury that has very different expectations for recovery than a severe brain injury, where you're going to have a much different spectrum of possible outcomes. So when we talk about this, it's not just like, oh, it feels like worse. It's grounded in some clinical determinations. And these are decisions and classifications that happen, again, pretty early in the process of being assessed for injury. So in terms of the primary types of traumatic brain injury we see direct impact injuries. So you also hear people say, you know, blunt force trauma. You also see that like on CSI and Law and Order, they'll talk about blunt force trauma. We have acceleration and deceleration injuries. So those are injuries where the body and the brain stop and start at a really rapid rate. So this is something that you might see, for example, in a car accident where you're moving at a static speed and the car stops. Your body is still moving. And so you have this rapid movement. Whiplash injuries also present like this. You may have a really hard acceleration, deceleration. You see this a lot in sports related injuries as well. And anytime you have an impact to the brain, you're going to have some movement, hopefully not too much movement, perhaps some movement of the brain inside the skull within the cerebrospinal fluid. And so with that brain moving around, that's not what it likes to do. It likes to stay in place. And if it's bouncing around, there's more likelihood that it's bouncing on your skull or other structures that could cause bleeding, swelling, and just generalized contusions. And then we have shearing types of injuries or shockwave injuries. Shockwave injuries are much, less likely to be seen. These are things you typically see in, combat contexts and situations where people are exposed to explosive blasts, sometimes really sonic related injuries, which there are some evidence of sonic related injuries that have occurred. These are things that are more atypical kind of in day-to-day life, but they do occur. And then we have penetrating head wounds. So this is also an injury where we have something enter the brain space, and sometimes it's very simple. It's something goes in and gets stuck. That would be like a penetrating wound. And this diagram here, it's using a bullet as an example. A perforating wound. So when you have a fragment or a piece of something that goes completely through the brain space, and then a ricochet injury where maybe you have something come in and bounce and then get stuck somewhere. And then you can also have penetration from objects. So sometimes people will come in and they have an object that has been pushed through their skull into their brain space in some type of way. And it can be, full or partial integration into the brain space. So all of these are different ways that the injury can be classified, but it's separate from those injury parameters we talked about. So for example, you can have a penetrating head wound, which is very stunning and remarkable in the fact that we don't want anything ever going inside of our brain space. But simply because something is very invasive doesn't necessarily mean it will meet criteria for being, a more moderate or severe injury. Again, those injury parameters are more due to those other clinical features of the injury and not necessarily the mechanism of injury. Though certainly having a bullet, having a fragment of anything go into your brain certainly raises the likelihood that it's going to be more severe. And by virtue of the fact that there is an intracranial finding, we're already not dealing with a concussion. We're dealing with at least a mild complicated injury, and likely more severe, but these aren't always so cut and dry.
Chelsea, can I ask you a question real quick?
Of course.
So Lisa had put a comment in the chat, about changing severity measurements away from like the mild, moderate, severe. And I think this kind of goes with some of the things that I'm seeing where we're trying to get more closer to, precision medicine in the space of brain injury and kind of getting a little bit more personalized. So you talked about like a lot of different ways that we might classify here. So how have those classifications changed over time, and where do you see that going in the future?
Yeah, that's a great question. There's a lot of discussion about, are these groupings very crude? Do they need to be specified differently? How is our science changing, and how is that going to influence our ability to measure things that right now we're calling unmeasurable? So for example, there are injuries where we're saying there's no intracranial findings. We don't appreciate any change in the brain space, where perhaps it's that we don't have imaging or techniques sensitive enough to detect it. In 20 years, we may feel really differently about injuries we're calling mild right now, because we don't understand how the brain is being affected. In terms of how things are progressing clinically, I think we're still solidly, very much using the criteria that I discussed. And I didn't go into complete detail about all of the different parameters and how that's determined. Because there's still a lot of clinical utility there. I think it has a lot to do with how we're going to be able to measure some of these things in the future. But we do know that subjective impressions of impairment often don't align with expectations of injury and sometimes what we expect clinically. And that can go in both directions. Sometimes we have impressions of impairment that exceed expectations. And sometimes we have people that have impressions of impairment that are far below what we would expect. And so, getting a better sense of the personal experience of each individual that has an injury, how that does or doesn't map on to these clinical markers, and if we're missing things and trying to make these classifications, and perhaps we need to expand what we're doing. I don't know that there's been a consensus. This is what you sent, and I'm assuming you're referencing, the National Academy of Science. They have a consensus report. This is not something that has fully been adopted in the clinical space yet. So there's more to come there. But I think that there's a lot of uncertainty, and medicine is, as fast as we are to adapt, we're also a bit slow when we're trying to coalesce around a new process, especially if it's a new process of assessment.
That's a great answer, Chelsea. And just one thing to add on to it is, thinking about what we do in the research space around this is that, at Ohio State, we're doing a lot of things when it comes to biosensors, new ways to image. We're trying to get closer and closer and closer to being able to offer imaging more readily, as people progress through their recovery. Sometimes you might only get that at, a couple intervals. And so we want to make sure that we're getting more continuous imaging or assessment, objective measurements of how you do. Some of that might be wearable sensors that you take home with you so that we're getting data in between appointments, right? Yeah. Sometimes, you might just be feeling a certain way during an appointment, but you might be feeling very differently at home. How can we tell the difference between those two things? And a lot of times these are things that can be as simple as a Fitbit watch. Yeah. But those are hard to get. They're still in the developmental phase. So we're very, very early in that process. Some of the other ones, maybe like biorepositories, Chelsea, where we're getting these large data sets of, what does a TBI look like? Or, how do the different kinds of TBIs look when you do MRI imaging, and trying to get more power into that, because we really don't have too much there, so far. I mean, how do you respond to that? I mean, agree, disagree? How does that affect the clinical?
I agree with many things you're saying. Ecologic momentary assessments, so like EMAs, like the wearable technologies, that kind of getting a sense of what is actually happening to you more on your normal functional suite is really important. And that's something that most of our clinical assessment, whether it be imaging or other functional assessment like neuropsychological assessment, misses. We get a snapshot in time rather than this consistent observation of changes in your inner we call it intra individual variability. So we know that there's variability between individuals, but there's also a lot of variability internally. So how I'm functioning right now at 6:50 p.m. is a little bit different than probably how I was functioning this morning at 10 a.m. Right immediately post giant coffee. And it's going to change tomorrow. How I'm functioning at 6:50 tomorrow night is going to be different than how I'm functioning now. And so your capacity for functioning changes. And that's part of being a human being. But also understanding that in the context of injury is something we're working on. I will say that with imaging, imaging is one of those parts of assessment where, it is very validating and helpful to be able to look at an image and see defect, right? It's like, okay, there it is, right? There's the thing, there's the problem. And what we find in research across the board is that, we don't necessarily have the same understanding about how structural changes to the brain impact functioning. So what we see is problems in both directions. I can look at an MRI that has a clear and focal lesion in a particular area. And based on what I know about neuroanatomy and my training, I can probably make a pretty good guess about, well, with a lesion in that area, in that space, with these comorbidities, you probably would see these types of changes in someone's cognition, their behavior, their functioning generally, their motor functioning. But without doubt, almost every time when we actually meet that person and assess them, our expectations and what is actually happening may be very different. There are times when images look really rough and we're expecting, man, there's going to be a lot of impairment here. This is going to be a really, really messy situation. And they're actually doing quite well. I've also seen brains that are clean as can be, looks beautiful, not a problem in sight, and that person is not functioning well. And so structure does not always equal function. Certainly problems with structure beget problems in functioning, but it's not one-to-one, and it's not a certainty. And so if we rely only on imaging, we miss a big part of it. And that's why functional assessment, things like neuropsychological assessment, and it's why, self-reported functioning and all these other pieces, that's what matters. So when we're looking at the pie chart of what's happening for this person, imaging is but one sliver of that pie chart. It's one piece of data. It tells us something, but it doesn't tell us everything. We've got to have other information to help flesh out really functionally, what does this mean? And what does this person need to function optimally or at their best, considering that they have an injury of this type. Does that make sense? I know that was long-winded.
Yeah, no, it was great. It was great. I have like 10 more questions, but I'm going to just stop myself and just let you keep going.
There's so much to say. Well, in that same vein, that's actually kind of a good segue because, when we think about brain injury and traumatic brain injury, we're thinking about these issues with something coming into the brain or maybe something, making the brain bounce around in ways that it shouldn't. And those are what we call the primary injury. So that's the first thing that happens, that focal injury to the scalp, the skull fracture, the contusions, the shearing, the intracranial stressors and pressures that happen right immediately and secondary to that impact or that movement of the brain. But that's not the only thing that causes trouble. It's the secondary things that also come up that are leading to further injury. So if it was just that the brain moves around, it bounces and it gets a little upset, gets a little frustrated, has a little bleeding, and that's the beginning and end of it, that would be a pretty cut and dry situation potentially. But we have our body is an ecosystem that reacts to changes. And so when your brain starts to swell or has bleeding, your body recruits a lot of immune resources and inflammatory processes to try and handle that injury. And so those things can be helpful or hurtful. So what you see after injury, not all injuries, but these are some of the things you can see, is you can see pronounced swelling or edema in the brain. You can have changes in blood flow, so reductions in blood flow that cause death to the tissues, the cells, increased intracranial pressure. You can see infection, abscess, seizure. There's all sorts of things that can emerge. Vascular changes, problems with how the vascular system is functioning or injury to the vascular system causing a secondary bleed. And then we also have something called a neurometabolic cascade. So as the brain tissue is reacting to the injury, you have changes at the cellular level and how chemicals, so like calcium, all of those electrolytes are moving in and out of the cell. You can have impaired function at the neuronal level, changes in your brain metabolism, and just generalized disruptions in how your brain is sending signals. It functions with neurochemical signaling. And so you can have changes in how that process works. And that can also change, your seizure threshold. That also helps your cells know, should I be working or not working? And changes here can, again, also cause like cell death or damage to the neurons. And then as those neurons die or become damaged, they send out chemical signals to say, I'm dying, I'm hurt. And then we recruit other resources to help clean up the waste products of those injuries to those cells. And so there can be all sorts of messy things that are happening that cause these secondary complications. These are things that are natural, but they also are problematic because they can cause other changes that we can't control so easily. And that's what the role of medications and early intervention to manage changes in metabolism, changes in infection risk. That's why often we're giving you seizure prophylaxis. If you have an early brain injury, we're trying to reduce the risk that you have a seizure. We know that if we do that early on, we reduce your overall risk of seizure, and your recovery trajectory is much different than when we weren't doing that. And so there's so many other things to consider, not just that initial injury, but all the other things that happen around that injury too. So when someone gets hurt, no matter what it is, whether it's a brain injury or any other type of injury or a change in someone's health, they bring their entire self into the situation. We don't preferentially get to bring just a certain piece of ourselves. It's just our whole self. If I get in a car accident tonight, I'm bringing my whole self, all my baggage, all my messiness, all my health conditions, my social context, my family, my personality traits, my cognitive abilities, my culture. I'm bringing all of that into my situation. And so everything that you have in your life comes into the new scenario with this new stress of an injury. And so we can't expect that when someone's injured, that all of those things suddenly go away. We have this new clean slate to work with. The brain that is injured is very important. Who that person is, what is their context, how are they functioning before, what are their needs medically and psychiatrically, psychologically, socially, because those needs are still going to exist. Those tendencies and preferences are still going to exist in this new context. They may be transformed in some way. The volume may be turned up or down on them. And they're going to have new changes in their ability to function potentially that are going to also be influenced by some of these factors too. And so very broadly and crudely, TBI and brain injuries in general. So anytime we have change to the brain, there's a possibility that it can result in changes in a bunch of different spheres. So the big ones that we want to consider are motor function. So how does the body move? Sensory functioning. So how do we feel and interpret our environment? And that's not just like how we feel like on our skin or that more crude, hot, cold, pain, pleasure side, but also our hearing, our vision, other aspects of how we interpret the world. It can also cause changes in your emotions, how you think and feel about yourself and about other people. Changes in behavior. So those visible signs of functioning. So emotions are sometimes invisible or often invisible. The behavior is what we see, the tearfulness. Tearfulness is not an emotion. It's a behavior, right? And so I don't know what you feel, but I can see that you're crying. And so separating those things out is sometimes important because we have conditions in brain injury where you might have tearfulness, but you don't actually feel sad. It's a neurologically driven dysfunction and emotion regulation and emotional expression. We also have changes obviously in cognition. So your ability to understand, reason, learn, to pay attention, weigh information, read, write, all of those areas. So you may have changes in one or all or none of these, depending on the type of injury and those secondary injuries that you're experiencing. And also within the context of your prior medical situation, someone for whom they're having maybe a second or third TBI, or they're having a TBI on top of having a prior stroke, we're looking at a couple different factors that might be impacting their functioning and their well-being. So ultimately, outcomes after brain injury not only depend on like the type and severity of the injury, but all of these other pre and post injury factors. And we'll add to the pile that we're already talking about, things like genetics, history of trauma experiences, personality factors, family mental health history and neurologic history, drug and alcohol use history, the presence or absence of life stressors, socioeconomic issues, limitations financially, and those other health comorbidities. So again, it's not necessarily just the nature of the injury, but the nature of the brain that has been injured, and what that person and their context is also dealing with. So this diagram is from a really helpful article, and I did make an alteration to it because I didn't like it, and it was using some outdated terminology about mental health. So pre-existing psychiatric conditions, they refer to it as an Axis 1 condition. That's an old way that we used to talk about different classifications of psychiatric conditions. So I changed it. But you see here that all these things are interacting and contribute to what ultimately is the neurobehavioral outcome after a brain injury. So what does it look like in terms of this person's ability to function after their TBI? All of these things are coming to the table. But more importantly, they're not just coming in and all independently contributing. What's happening is that all of these factors are constantly and dynamically interacting with one another. It's not just linear. It's not just A to B, that this plus this equals this. It's how all of those pieces are dynamically interwoven. We are complicated beings. We are human beings. We have a lot happening for us. And so how we react and respond and how we heal from injury is influenced by all of these factors happening concurrently and influencing one another as well. So it's bi-directional, and it's also a circle. So whenever we try and distill things down, and we want to so badly to make them seem simple, we want it to be simple in A plus B plus C. If you're ever tempted to simplify it, know that if we're talking about human beings and human behavior, and we're talking about the brain, it's likely much more complicated than we'd like it to be. And there's probably a lot more influencing the situation than what it seems on the surface. So we're going to start to talk a little bit about mental health next. And obviously we're touching on some pieces of that so far, but does anyone have any just initial reactions, questions at this point before I go on anymore? Okay. All right. I will keep going. So then that brings us to this question of what is mental health? Mental health is a term, a phrase, if you will, that we hear a lot. We hear all the time. And I think we hear it, we're like oversaturated with, like, to the point where, like, I don't know what mental health is anymore. Is it a condition? Is it something else? Is it just how you are? So the best way I think to discuss it is that mental health is our emotional, psychological, and social well-being. It's how we feel, it's how we think, it's how we act. It is all the stuff that makes us who we are, in terms of how we interpret and interact with the world. So it's not a diagnosis. You don't have like good or bad mental health. You just have like what your mental health is. Just like when we talk about what is your physical health status, there's a lot of things that go into what that looks like and how we're defining it. What is your mental health status? There's a lot of things that go into that, and it may include a psychiatric condition or it may not. It's really, how is this person in the world? How do they think, feel, act, behave? How are they? And so generally, when we're using this term, we're talking about an overall picture of someone's psychological and emotional functioning. It might consider psychiatric conditions, but it's not exclusively related to a presence or an absence of a diagnosable condition. And simply because someone has a diagnosable psychiatric condition doesn't mean that they have bad mental health or good mental health. And I think we should be sensitive about not drawing big generalizations about someone being in a good state or a bad state, but more what is the whole context, and really trying to flesh that out rather than drawing binaries about what's good or bad. And so you can have a psychiatric condition and still have good mental health, still have a mental health status that is functioning well within your scenario. So it's not something that is directly tied to having dysfunction. And I see maybe some stuff in the chat and I want to make sure.
Just comments that you're doing a great job.
Oh God, oh sure. Well, carry on. If there's a question for me, just throw it out there. But we do want to be sensitive that with TBI, and there are different things that are true for other conditions. I'm just going to stick with TBI for now. There are higher rates of certain psychiatric conditions than others. And so mental health under that umbrella, we do want to talk a little bit about these sorts of conditions, because they can impact recovery and how people are able to manage all the things that happen for them after an injury. So the primary mental health comorbidities, and that's just a big word for stuff that comes with it, things that come along with TBI at times, are depression. There are much higher rates of depression developing after brain injury. Trauma-related conditions, and the two that come to mind that are the primary ones to be aware of, are acute stress disorder, or ASD. That is the trauma condition that is immediately after the traumatic event. And if the experience and the symptoms in that context last longer than a certain specified amount of time, then we might be talking about conversion to post-traumatic stress disorder. So again, you might get diagnosed with acute stress in the immediate aftermath after a trauma, but that's not a diagnosis that you would carry if you have a trauma-related condition over the long term. Anxiety-related conditions are very common after TBI. Development of issues like worry, sleep, rumination. Panic attacks are particularly common, especially in younger adults that sustain moderate and severe brain injury. And there's a big difference. Older adults are less likely to develop panic attacks after TBI. And then as well, adjustment to injury, adjustment to disability, and functional changes after TBI. This can rise to the level of classifying or qualifying as a disorder. We have conditions called adjustment disorders, and they have different sub features. So we have adjustment disorder with anxiety, adjustment disorder with depression, adjustment disorder with depressed mood or behavioral dysfunction. And so those are qualifiers, but ultimately, those things are expected. When we have big changes to our health and to our life, it's expected there's going to be challenges and there's going to be growing pains adjusting and adapting to whatever might be happening. And that's not a disorder, but it is something that can be treated, that can be supported. And we have a lot of good evidence base and how to work with individuals who are adjusting to changes in this area. There are some individuals where their difficulties do rise to the level where it impacts their ability to function, or that it's making it harder than it otherwise might be if they didn't have this onset of severe mood issues or anxiety that's related to their adjustment condition. So sometimes you'll see this as a condition that's discussed, but all individuals that go through major health changes are having some degree of adjustment that's occurring. And this is obviously intersecting with one's overall mental well-being and their well-being in general. The other big comorbidity area that's important to point out is substance use. So substance use is a risk factor for TBI generally. So individuals that sustain TBI, it's not uncommon that they will have been under the influence of alcohol or other drugs at the time of their injury. And this is not meant to be a statement about cause or blame, but
I think we lost her for just a second. She's going to pop back on. It'll be nice when we go back in person, right?
Say again?
Yeah, you froze for a little bit, so we were saying,
oh, no.
It'll be nice when we go back to in person.
Oh no, where did I freeze at? I'll go back.
Just a couple seconds ago for you. So maybe if you could just kind of, you were talking a little bit about just what the comorbidity area is with substance abuse.
Yes.
Maybe you can start from like the third point.
Sure. Yeah. So a pre-injury history of substance abuse is a risk factor for having a TBI. So individuals that essentially have what we call the rise level of abuse, so they've got substance use that is problematic and interfering with their functioning. These individuals might be more likely to be in car accidents, to be involved in altercations, physical fights, to be involved in assaults or to be assaulted. They're more likely to, for example, to lose consciousness or to have impairment due to substance use that might cause a fall or otherwise cause some type of injury. And unfortunately, substance abuse, misuse, and dependence is associated with poor outcomes after brain injury. It also increases the risk they might have a repeat injury, and also raises your risk for other health problems generally. And certainly substance abuse and misuse and dependence can impact your psychological functioning, your cognitive functioning, your participation in your life, and other areas that are important for you. And so then you can see how very quickly substance use can make life really complicated and very hard. And it can be even more difficult if you're dealing with changes in your emotional, psychological, or cognitive functioning after a TBI, or a motor functioning as well. And there is some evidence that risk for substance use can increase after TBI. That's more true for individuals that have pre-existing substance use, but there are some individuals that develop a substance use disorder after brain injury. And there's not clarity about who's at most risk for that, but it certainly does occur, and it's something to be aware of, and that individuals do get typically counseled about after their injury, and the recommendations to avoid substances, and particularly alcohol and cigarettes, which are illegal substances, that people reduce use of that after injury to help with their recovery and to make sure that their brain has the best chance of being able to recover well. Some individuals, will not use substances for the remainder of their life after an injury of this type. But there's a lot of variability in how people proceed. The average recommendation in most medicine settings is to recommend at least a year of abstinence from substances. But there you'll see other people recommend other considerations. So I think there's some differences in the clinical guidelines. And so you may see different physicians or psychologists make different recommendations. So before I move on to other levels of medical care that are related to TBI, any thoughts, questions about anything I've said so far?
Go ahead, Dimas.
Yes. Question. Find everybody back on the screen again. Hold on a second. Okay. It's very nice to meet you, Chelsea, and thank you for your teaching and everything. Okay. It's good to see you, Kadar.
Yeah, you too.
Good to see you, man. Good to see everybody. Good to see you, Perry. Good to see you, everybody. So I've been post TBI for 15 years. I suffered a severe traumatic brain injury when I was 22 years old, and is there an amount of time after your injury that you are more prone, or they watch out for seizures? Like, do you have to be concerned about getting a seizure like later in life? Like, I'm 15 years out. That's my first question. Does that make sense to you?
Yeah, no. So it's so if you have any TBI, your risk for seizure generally is elevated relative to like the population of people who has never had a severe brain injury. But what the data shows is that if we can prevent seizure within the first week, so that first 7 days, and then ultimately within the following month, the odds of you having a seizure dramatically reduce. So like if you have a seizure within the first week following your injury, your odds of having a second seizure, I think, are closer to like 30 or 40%. But if we can prevent that first seizure within the first week, your odds of having a seizure at any time in the future go down to like less than 5%. So it's a really dramatic reduction. And so obviously, without knowing your specific medical background, the expectation that you would have an onset of a new seizure condition, that many years after, would be pretty low. It's not absent, but I would not think that in the absence of other risk factors that there would be concern for that, especially if you haven't had any other seizures.
And it doesn't help that there's different types of seizures. Like there's seizures that don't show any type of signs, like a grandma seizure, and or when you go and you think you're having a seizure, and then you go and get it looked at, and then they hook you up to that test, and it doesn't necessarily detect that you had a seizure because it's already past
Sure.
the seizure. Does that make sense? So it's hard to detect if you ever had one or whatever. But yeah, I guess my second question is more for Catherine Brownlow, but I'm just going to ask you real quick. I take Depakote or Devalprox, which is it's a mood stable. It's not only an anti-seizure, but it's a mood stabilization medicine. So that's what I take it for. Now, if someone, I kind of worry about stuff. I worry about stuff a lot, really, but that's my anxiety. If for some reason I were to get off of Depakote in the future, would that make me like susceptible to having seizures because it's an anti-seizure medication and I've been on it for a while? Does that make sense?
Yeah, it's a great question. And I hope you come next week because Dr. Brownlow is a perfect person to ask about that. It depends on what the medication is being utilized for. So I mean, say for example, and without using you specifically, because your personal medical history, you're very generous to share, but I don't want to over question you. If you're taking Depakote for the mood stabilization effects, and there's not concern for seizure, that's probably going to be less of a consideration. If you've been taking Depakote specifically to mitigate the risk of seizure, then your risk threshold will probably be higher. The other thing to think about is like with medications like Depakote and anti-seizure, anti-epileptic drugs in general, those are drugs you have to slowly taper off of. You can't just stop taking them. And so often during that taper period, there's going to be a lot of attentiveness to, whether or not you're having neurologic changes that would mean that, we're doing this taper too quickly, or it's not safe to taper off this medication. We are seeing signs that you could have a seizure. And your point about, monitoring for seizure is very well taken. Even on continuous EEG monitoring, or maybe you're hooked up for 24 hours, if you don't have a seizure during that time, then they don't see anything. And it's very difficult sometimes to make sure you're there when you need to be and that the event occurs so that it can be surveilled and monitored. And with seizures that are those absence type, where maybe they're a staring spell, those are harder to detect. There are some psychiatric conditions that can mimic seizures. And so that's another consideration when you're trying to figure out what might be going on, for individuals that have, other jerking related movements, staring spells, inattention, tics, motor tics, things like that. There's a lot of potential overlap with other conditions. And so it can be hard to tease out if you're not having those, what we used to call grand mal, those big motor seizures. It's kind of hard to detect. So those are all really good points. And I think Dr. Brownlow will be able to get more detailed about that with you. She's the medication expert.
Yeah, Catherine, Dr. Brownlow used to be my doctor actually. So it's just a matter. Yeah, she's my psychiatrist. Yeah, or she was my neuropsychiatrist. So she's pretty awesome.
Yeah,
Thank you very much, Chelsea.
Of course. Thank you, Jonas. And I see Pam maybe has her hand up.
I do. Thank you, Chelsea. I'm 4.5 years out from, I'm a 4-time brain injury survivor.
Right.
And I see Dr. Mishu, and I just wanted to ask a question. In the last year, I had COVID. I had a really nasty case and it affected the brain injury. So I took a step back.
Yeah.
And I've recovered greatly in the year. But one of the things, we don't know if it's from the last injury itself, or the accumulation, or COVID did something, but I've developed kind of all over body nerve pain, as well as a slight slurring of my words occasionally.
Okay.
Are these things that occur with brain injury patients after, like I said, I'm almost 5 years out from my last injury. Is this unusual?
So I would say in general, yes, it would be atypical, not knowing any specifics about your injury or other medical status, and even with multiple TBI, it would be atypical that, 5 years later after an event that you would have a new onset of a new symptom. Generally we see people, they're either getting better or things are kind of plateauing. There are exceptions to that, but to have like a new focal symptom, new intense pain, changes in your language, that isn't necessarily expected. And so it may be something, again, to see your doctor about, and especially if it's, consistent, interfering, it's not just a one-off, if it's feeling like there's something really different happening, it might be worth, getting it investigated. But certainly aging also plays a role, as we age, we can also have changes, in how our brain is functioning that could cause changes that are, not necessarily related to TBI, but just related to changes in brain functioning. Also, stressors can play a role, and there could be another medical condition that's emerging, or there could be some other new medical issue. So it's why it's important to kind of rule out and kind of get closer to what might be going on. So on the surface, it would be slightly atypical, but I hate to put my foot in my mouth without knowing, the full situation. But I think Dr. Mishu is a good person to talk to about it.
All right, excellent. I appreciate your help. Thank you, Chelsea.
Yeah. Anybody else?
I don't see anything else in the chat, Chelsea.
Okay, time is flying. We're already getting close to the end. So
Yeah.
we'll talk, I just want to move a little bit quickly through the levels of medical care. If you were to have a brain injury, this is kind of how it happens. A brain injury that requires hospitalization. So in the trauma level of care, so this is if you come in, as a level 2, level 1 trauma, you're being presented to the hospital in emergency status. You're not driving yourself to the ER in this situation. Your family's probably not driving you to the ER. You're having an emergent and very serious health situation that requires you to be transported by EMS, whether it's a helicopter or an ambulance. And so in the trauma-related phase of care, we are doing a really rapid assessment of your injuries. We are focused on resuscitating you and providing immediate life-sustaining treatment. We're dealing with life-threatening injuries and figuring out what's happening and how do we quickly get things stabilized. This is a period of time where the injured person likely has very limited awareness, if at all, of this level of care. That can be due to the nature of their injury. So if their brain injury is severe enough to cause a change in consciousness or amnesia, but also this is a time where you're probably getting a lot of medications, heavily sedating medications. You may actually be sedated or intubated. And so this might not be a time that you're much aware of what's going on. At this time, we're not really able to interact with you in a meaningful way about your experiences. And so this is the rapid assessment and stabilization part of care. After that, you may move into like an ICU level of care. So this is intensive care unit. Critical care is another way it's referred to. And in this setting, you still need a lot of medical care. You're getting ongoing medical interventions. You're still being stabilized. And a person may or may not be awake during this period of time. And again, it could be due to injury factors or could be due to sedation or the nature of medications that are being provided. And so if someone's able to communicate and interact at this phase, they're going to start to meet with consultants about what's going on. And we're going to start to sort through what they're experiencing, get their history. I work in this environment. So if someone is able to interact, I'll be there at their bedside and trying to establish a way of communicating and establish a way of getting at what they need and what their experience is. This can be very important because it can be very stressful to be in this type of a care environment. And so trying to get ahead of stressors, helping people cope with all the things that are happening to their bodies, all the uncertainty that's happening, the pain and distress that comes with that. And so in this phase, we're going to start to very early in small ways, assess cognitive, psychological, and behavioral functioning. And there's many different types of people that might be working with someone here. So myself from psychology, we also may have neurology, psychiatry involved, depending on what's happening. We're also going to be working with therapists like physical and occupational therapy, speech therapy, and we're using a really close team-based approach to assess what's going on for this person. And then in acute care, this is kind of the step down. So after you've been through an ICU level of care, you may move into an acute hospitalization, which means you're stable enough to leave ICU. You probably may have less nursing needs, but you may still have plenty of medical care. At this point, we're going to be focusing a lot more on rehabilitation, either restoring things or compensating for things. And this is where we do more intensive assessment and intervention for cognitive, psychological, and behavioral changes. For what I do, I'm going to be working very closely with the individual about, educating them, treating any new anxiety, mood, or adjustment issues, trying to mitigate stressors that may be adversely impacting their recovery and adaptation, starting to talk about how their body is different, what they're noticing, and kind of acclimate them to what's happening even further. And then after acute care, often, but not always, we might go to inpatient rehab. And so in this phase of care, we're kind of out of the woods medically, where we're maybe not so worried about you having an acute decline or decompensation. And it's this heavy focus on rehab and returning to your life roles. So looking at mobility, your ability to do your self-care, your ability to do higher order things like pay your bills, drive a car, go to work, manage a schedule, manage your medications. And we're starting to talk about leaving the hospital environment. So getting out of the medicalized setting. And so people might be going home, they might be going to another place. But ultimately we're trying to get people moving out of hospitalization. And so in this phase, you'll see even more psychological support, working intimately with your therapist, your doctors, about how do we help this person optimize their ability to function? How do we address parts of their life where maybe they're not going to achieve independence, or they may not achieve independence right now with this skill? Sometimes we're in a situation where the nature of someone's injuries prevents them from being able to be an ambulator, from walking. They might need the use of a wheelchair, other devices. They may need help for some of their self-care, or need some type of assistance. How do we work through those challenges psychologically, the grief and loss and the feelings of uncertainty that come with having a really dramatic change in your ability to function? And then we go, hopefully, into an outpatient level of care, where you're no longer in the hospital. You might be at home in a skilled nursing facility, or maybe another community placement like a group home or some other supportive housing environment. And you're going to be getting even more therapies, whichever ones you need. Hopefully psychotherapy if you need it and want it. You're going to see specialist physicians for follow-ups, returning to your primary care doctor, and hopefully reintegrating into other life roles. This is also the period of time where you're going to undergo a neuropsychological or psychological assessment. We typically do those types of assessments later, after we've had more time to recover. And then also look at functional assessments for returning to work and driving and other like higher level activities when it's appropriate. And there's all sorts of interventions that we're doing and things that we're looking at across lots of different specialists to try and address all of these goals and all of these needs. So there's many different types of people you might interact with, and lots of different interventions that could be chosen to help with these sorts of things. So that is the bulk of the content, and we are just right on time. So what are the ongoing thoughts or questions, concerns that are coming up right now?
So we have one question in the chat, maybe is a little bit unrelated, but it goes back a little bit. So we're talking about traumatic brain injury. We've talked a lot in the research side. I mean, Chelsea's, the circles that you and I, work in, about making sure that we're recognizing anoxic brain injury.
Yeah.
And sort of the effects of that. Can you talk a little bit about, and Betty, I hope I'm getting the gist of what you were trying to learn, maybe how mental health can play a different role or is different after an anoxic brain injury versus a traumatic one. Sure.
And Betty, please speak up if you feel comfortable, or if you want to clarify what you mean. So anoxic brain injury for everyone is, when you have a lack of oxygen, an oxygen debt to the brain that causes injury to the tissue. So there is anoxic brain injury, which a complete lack of oxygen. There's hypoxic injuries. So hypoxic injuries mean there's some debt of oxygen to the brain for typically a sustained period of time, which sustained in the time course of our brain is very short. So I mean, 1 minute of oxygen debt is a long time for the brain. 2 minutes is an eternity. 3 minutes is death. So we're talking about typically not a large margin. When people have a fully anoxic brain injury, so a period of time where their brain does not get oxygen or perfusion, we can see this sometimes when people have cardiac arrest, where their heart stops pumping, they lose consciousness, and it takes time to get that perfusion back. In instances of toxic exposure, so you're exposed to substances, typically gases, that reduce your capacity, overdoses that compromise respiratory function, respiratory failure conditions where you're not getting appropriate oxygen to your brain. Anoxic brain injuries have really hallmark cognitive symptoms for those people that survive, because these injuries are often very severe. what we see are really hallmark memory features. Well, people may have difficulty forming new memories. At the most severe end of the spectrum, someone might not be able to remember something that happened really recently. For other people, it's just very difficult. You may also see motor dysfunction. And in terms of mental health, a lot of that is couched within, again, their pre-existing mental health context. There can be a lot of distress associated with having injuries of this type, because it's often going to have pretty major impacts on someone's ability to function cognitively and socially. There's also considerations in anoxic brain injury about, emotional expression and whether that has been impacted because of neurologic damage. Depression and concerns with anxiety that are secondary to, again, changes in health and well-being. And someone with an anoxic brain injury, depending on the severity, may have changes in their ability to walk or to move, which are going to have even greater impacts in their ability to interact in the world the way they want. So is there anything more direct that I could speak to or think about with the question about anoxia? Because that's a really great question. And I see
maybe you got it right, but let's say we'll see if Betty has any clarification for that. Darcy had asked here, so she's had around 11 concussions across time, but some time ago, has had a seizure after, and continued to have a type of absent seizure monthly since 2004. So are you aware of any imaging tests that could test for this?
Yeah, so you can't detect seizure on imaging. So what we can detect on imaging, meaning like MRI, CT scan, DTI, those sorts of things, we can detect structural changes, because a seizure is a functional condition. So it's a misfiring in the brain. We can't really image that. So that's why the standard for identifying seizure is EEG, so continuous encephalogram monitoring. And like we were talking with Dimas earlier, if you're having one a month, the odds that you're going to be on an EEG monitor at the time that happens, are hard to say. And so unless you have like a witness seizure or a seizure that's, under surveillance under EEG, it's going to be really hard to understand and get a diagnosis. The other thing to think about is, absent seizures can mimic a lot of other conditions, psychiatric conditions and also motor issues. And so it might be helpful to think also about other functional assessments, neuropsychological assessments, and other ways of kind of getting at, when does this happen? Are there triggers? Are there not? And is there something else that could be going on? And without knowing your specific situation, again, I'm not sure. But if we're trying to detect seizure, unfortunately, at this point, the best we have is EEG. And it's kind of hit or miss. So if it doesn't happen under that surveillance period, they're going to say there was no seizure activity detected, which doesn't mean that you don't have a seizure, and it doesn't mean you don't have a seizure related condition, but it means that we couldn't capture it. So it's pretty hard. But if you have, like, say, for example, a brain tumor or a lesion, we may be able to identify that it could be an originating site of a seizure. But that's not a confirmatory thing. So just knowing that there's a structural abnormality, if there is one, doesn't make the diagnosis or doesn't give a lot of clarity to what might be happening with the seizure. So unfortunately, I don't know. I wish there was a better way.
Thank you very much. If I can just say that, that's pretty much the most common test that's been done is an EEG. Mm-hmm. And I have a BA in psychology and didn't understand that. So thank you.
Of course. Yeah, I think it's misunderstood. And what is said to people, come in, we'll put you on this machine and we'll see what's going on. And then they go, oh, well, nothing happened. And, that's why sometimes they'll do like a continuous monitoring, like a wake EEG. So like they'll force you not to sleep for 24 hours. I don't know if you've had one of those. It's not pleasant. Trying to induce circumstances that would promote the seizure. So sometimes that is more effective because a brain under stress is a brain more likely to have seizure in some conditions. But they also don't want to induce seizures. Sometimes for certain seizure conditions, and this is more common sometimes in like pediatrics, they will do like stress-based EEGs where they will deliberately try to induce a seizure because they really need to know the subtype of seizure that's happening because they're trying to make a surgical plan or determine the right medication. But it's uncommon that they're going to try and really induce a seizure. It's a very rare circumstances, and that's a great question for a neurologist and an epilepsy specialist too.
So folks, I know we're over time here. I think we've had a really good conversation. So I want to do maybe like one or two more questions, but I got to get Chelsea back to her, her actual time off. So Demas, I see that you have a question, so go for it.
Yeah.
Just a quick question. Is it possible for a person to have multiple types of, do they just have like the one seizure multiple times? Does that make sense?
Yeah, there can be you can have different seizure types. Typically people experience like the same type of seizure, but it's not always the case. I will say that, anytime there's a always or a never, we're generally wrong. It's not always the case, but it typically is the case that you're going to have a specific type of seizure because often, but not always, you have a specific site in the brain where a seizure is originating, and the neurons react the same way every time. When they're triggered improperly, they kind of react and make the same inappropriate signaling every time. So it tends to produce the same type of seizure. But there can be differences, but generally you would expect to have the same seizure type.
Thank you.
Mm-hmm.
All right. So Chelsea, I have one last question.
Yeah.
So, so I think this is a very good overview of just what happens and a lot of the different pieces that you're trying to bring into play and understand as you're trying to make diagnosis and care plans and deliver that. So I'm just trying to think through, a lot of the people in this group have been, out of, the acute side of things, at least for some period of time. And, we have been living in a very challenging time over the last few years. I mean, that's to say the least, right?
I don't know what you're talking about. Everything's been
fine. Right. It's business as usual, right? And, I can imagine that has been, challenging in the mental health sphere, right? I'm sure that is something that you're seeing in the clinical environment. When you think about brain injury, when you think about all these kinds of stressors and what, as you said, the context in which we recover. What advice or what kind of thoughts do you have on just this very long, stressful experience that all of us have been facing if we have brought a TBI to the table as well?
Yeah, I mean, I think everyone has had such a unique and personal experience of what the pandemic has done, to them and how it's affected their lives. And, I think at minimum, we can all appreciate the level of social isolation, uncertainty, for those of us, that have other medical comorbidities that may make us more vulnerable to a virus like this. It's been terrifying. We may have lost faith in the people around us. We may have lost a sense of safety. Many of us may have lost people we love, or have seen people get this virus and have major comorbidities and very terrible outcomes despite surviving it. The amount of cumulative trauma is profound, and if you were to add into that having an injury to your brain that made it difficult for you to regulate emotion, to perceive your emotions, to communicate, to move about the world. I mean, it doesn't take anybody with a doctorate to tell you that that's profoundly stressful. I haven't talked to a single person, brain injury or not, that hasn't had some type of struggle the last couple of years. And I think realizing that it's a norm, that we're all in it, but that we can all learn better ways to try and cope, or learn how we can address these things in more healthy ways. I'm a person like anyone else, and I have healthy coping skills and I have unhealthy coping skills, and I pick the ones I need at certain times, and sometimes I choose the bad ones more often than the good ones. And so kind of realizing for yourself, where am I falling on this spectrum of being able to manage these stressors, and do I need more help to do it, and what does that help look like? You know, for some people it's psychotherapy, for some people it's trying to increase social context and connectivity, for some people it's, man, I need to sleep, for some people it's exercise or whatever it may be. There's no right way to handle trauma and stress, but there are ways that can serve us better and be more healthy. And so it's very personal how each person is going through, because one person is going through, man, I'm sorry I didn't get to go on my vacation, and the other person is like, I just lost my mom. Those are very different experiences, and sometimes ones that we can't build equivalency between.
Thank you for those thoughts. So last question in here, I think this is a very good question. So in order to see a neuropsychologist, if this is not somebody that you're seeing right now, would you need a referral from a doctor? What's that pathway?
Yeah, so yes, you do. You can self-refer. If you were to call my office, for example, what they would tell you is like, call your PCP or call, whatever doctor you're seeing regularly and ask for a referral. So like usually we can help you get what you need. But yeah, you do need a referral, and often for a neuropsychological assessment, your insurance company wants to like get a pre-authorization, and they want typically like a medical justification for the assessment, because it is a very expensive and lengthy assessment. So they often will request that you have it's kind of a checkpoint. Like if you can't get a doctor's referral, then you probably don't need it that bad, which means you shouldn't pay for it, sort of thing that happens. So you do need a referral. But you can get one from any physician. Typically our referrals are from, primary care medicine, neurology, neurosurgery, psychiatry, physical medicine, and rehab. So if you have questions about that, certainly, I can send information to Kadar or whoever else about how you get in contact. And there's neuropsychologists at OSU in our department in physical medicine and rehab, which is where I am. And then there's also neuropsychologists in the Department of Psychiatry, which is where Dr. Brownlow is housed. So there's a couple different ways to get what you need. And depending on what your background and your set of conditions is, you may be better served in one department versus another, but all of us are, have excellent training, and you would be very, very well served in lots of either place. So it just depends on what you need.
Very nice. Okay. So I will follow up with you on that on Chelsea, and maybe we can send that back out in an email in terms of just what's that process.
Yeah.
So again, well, first, before I do anything else, thank you so much, Chelsea. This is a great overview. And I feel like we had great discussion. So thank you for doing this for us tonight.
My pleasure. Thank you all for being here. Thank you for asking great questions. I can't wait to read the chat, because I can tell you guys are having like a really robust discussion in here.
It's a good night for the chat. I
definitely want to read it. Thank you guys for being so nice and welcoming. And my contact information, let's see if I can go back if you guys want to jot it down, but I think you guys got the slides.
Yeah, we'll make sure everybody gets the slides too.
And if there's anything you need, just let us know. Happy to help.
So then also, folks, I'll just tell you real quick, we're going to be back next week, 6:30 with Catherine Brownlow. So we're going to continue the conversation. So if you had a question that we didn't answer, or if there's more that you want to learn, definitely come back, and we'll have, it's not going to be the same information. It's going to be a little bit new. And then I also want to just remind you that we have the Ohio TBI Summit on March 11th. It's free for survivors. You're going to get talks like this, lots of different things for you to learn. You can participate virtually. You can participate in person. And I'm biased. I'm running the conference, so I do want people to come, and I think it's good. But I hope that you find out that it is good as well. Until then, I hope that you stay well, that you stay healthy, that you have a good rest of your week. And hopefully we will be able to see you next week. If you're trying to go to the conference, I saw a question, you're trying to sign up for free, shoot me an email and I'll help you out. Okay. All right. Take care, everybody. Thank you again, Chelsea.
Yeah. Thank you guys. Have a good night.
Thank you.